Awesome. All right, I think it's recording now. So we'll go ahead and get started. So hello, everyone. For those of you who don't know me, I am Kara Partridge, and today our topic is kinetics, drug-drug interactions, and pharmacogenomics. So let's see here. Again, this is intended as a review. So, I mean, we just had a couple years of schooling. Hopefully this is just kind of to help you guys brush up on all that knowledge. I did get this from the 2020 RX prep book. So it's basically what came from there, kind of the underlined parts that they think are pertinent. And this PowerPoint is provided online. So if you need to access it after the fact or right now, it is posted. And then if we have any pertinent questions or clarifications, please feel free to unmute yourself and ask me, or we can wait till the end, or you can email me. And so these are the chapters. As far as updates, I haven't gotten the new book yet. So, but thankfully these topics today aren't really ones that like we're going to see guideline changes in that much. All right, so let's jump into it. So, kinetics. So I'll go ahead and start off with the difference between pharmacokinetics and pharmacodynamics. So pharmacokinetics is what the human body does to the drug, and dynamics is what the drug does to the body. And I kind of put a little example here of, you know, how we can remember this. And I'm sorry if your name doesn't start with a K, but this is how I remember. So for PK, it's what Kara does to the drug or what the body does to the drug. And PD is what the drug does to the body. So pharmacokinetics involves ADME, which is that absorption, distribution, metabolism, and excretion of the drug. And pharmacodynamics involves that drug concentration at the site of action, you know, having its effect, and then, you know, possibly the adverse effects as well. So for absorption, we're going to get into that first. So we see intravascular formulations and we see extravascular. So intravascular might be IV or IA, and so they actually surpass the absorption in ADME because they're going straight into the bloodstream. And if we jump down to that little visual I have, you can see that here. You're, you know, bypassing the stomach, intestine, all this stuff right into the bloodstream. Extravascular formulation, so by mouth, sublingually, buccal, etc. Those do involve absorption because they have to go, you know, from those sites into the bloodstream. So here would be an oral formulation from the mouth to the stomach, intestine, portal vein, liver, and then bloodstream. And enterohepatic recycling, that's going from the liver back to the intestine via the bile. Excuse me. So first pass metabolism, so that's when we have that extensive metabolism in the liver before our drug is even reaching the bloodstream. And then if we look at active versus passive transport, so that's just, you know, if it's passive, it's going from a high concentration to a low concentration, and active would be using transporter proteins. So when we're talking about absorption, an active ingredient in a drug has to be released first into dissolution. So it goes into the solution before it can then be dissolved by the GI fluids. So we have to remember that. That's kind of like a little side step that we see in the absorption. And the rate does depend on the dosage form. So we're remembering that IV is the quickest, followed by sublingual, orally disintegrating, then intermediate release. Oh, sorry. Yeah, it's immediate release and then extended release. And then hydrolysis, just as a reminder, so that's something that can destroy some of the drug formulations, you know, as they're being absorbed. And that's where we can see the protective coatings come in. And so those can help limit that degradation in the stomach. So we see like the enteric-coated dulcolax, for example, those coatings are helping to dissolve in a certain pH. So I think If I remember correctly, like the intestine has a higher pH than the stomach. I think that could be opposite. Correct me if I'm wrong, but that's why we have that coding on there. So it kind of is released somewhere else down the line. If we're looking at particle diameter, so decrease in a particle diameter can increase the surface area of these drugs and thus increase dissolution rate and absorption. So we can see that with micronized drugs with those very small particle diameters, kind of getting back into our pharmaceutics class here. And then they did list in the RX Prep book, I think it's called the Noyes-Whitney equation, and that kind of describes the rate of dissolution. They didn't actually talk about what it actually was, but that's worth mentioning, I guess. So solubility. So this is the rate and extent to which a drug can dissolve, and only dissolved drug is absorbed. So this is something we have to make sure we're looking at in these drug formulations. So normally hydrophilic, so water-loving, those are the freely soluble drugs usually. And then hydrophobic, which is the water, we don't like the water, but they like the fat, or that would be the lipophilic. Those are the more poorly soluble drugs usually. And then if we talk about bioavailability, so that's how much drug is actually reaching systemic circulation. And so that's the percentage absorbed from that extravascular source, relative to the intravascular administration. So a high bioavailability, so, we would hope for a bioavailability of 100%. So the higher the better. That would be more bioavailability. So actually an example here, so they give the example of levofloxacin and linezolid. Those are actually both 100% dose absorbed by mouth and IV. So I thought that was kind of interesting. But with other drugs, it might be a little bit different. So let's see, so more bioavailability. So here's a little equation here. We've seen this in kinetics before. So we're using the AUC, or the area under the plasma concentration time curve, which is also the total exposure of drug. And this is kind of one of the aspects that goes into that bioavailability equation. And so the PO right here that you see can actually mean any of the extravascular, so whatever dosage form you're comparing to IV. And then if we're going kind of between dosage forms with the same drug, this is the equation we would use right here. So the amount absorbed, and then the bioavailability, that should say of the new dosage form. Going into distribution now, so this is the process in which the drug molecules move from systemic circulation into those organs and tissues. And so the drugs that we want to see that will most likely have that higher passage and distribution will normally have higher lipophilicity, lower molecular weight. They're usually unionized and usually have low protein binding. So that's kind of like that balance that we have talked about before, in that, these drugs need to be dissolved, and that's the hydrophilic aspect, but then to be absorbed, they have to still have somewhat of a lipophilic aspect as well. For protein binding, we also have to think about this. So albumin is actually the most common protein in that drug binding, but only unbound drug can really exert its effect, and that means, the free drug, basically. So if a drug is highly protein bound, but serum albumin is low, actually, more drug will be in unbound form and thus may exert more effect. So that effect being therapeutic or toxic. And now we get into free drug levels. So in talking about distribution, so some of the assays can't tell the difference between a bound and an unbound drug. And so that's why we use these correction formulas to determine whether the concentration, to determine, with the normal albumin level. So the examples here being phenytoin and calcium. I think normally we'll see that calcium correction equation. So it's listed there just as a little reminder and kind of good to review. Let's see here. And then talking about volume of distribution. So this is actually a theoretical value, which is why it's sometimes referred to as apparent volume of distribution. And that's the concentration in the body related to the concentration in the serum. So how large the area of the body of that the drug is distributed into, basically. So, sometimes, that's when we talk about bigger people might have a bigger volume distribution, and sometimes we have to account for that in our dosing strategies. Moving right along. So now we're getting into metabolism. So this is a process by which the chemical structure is converted into other forms. And so we'll have a parent drug that is metabolized into its metabolites. And the primary sites for metabolism that occur are usually the gut or the liver. And that's where we'll see first pass metabolism. And so that's, metabolism in the liver before a drug even reaches systemic circulation. So if you remember that visual kind of on one of those previous slides, all these steps have to occur before even making it to the bloodstream. So, some drugs, there's not a great amount that makes it to the bloodstream because of this first pass metabolism. And then this includes phase 1 and phase 2 reactions. So phase 1 would be oxidation, reduction, or hydrolysis. And so phase 1 can terminate the activity of a drug or convert a prodrug to its active form. And so this happens by adding a reactive functional group onto the compound, which permits the drug to be attacked by the phase 2 enzymes. And so in phase 2, this is when we have conjugation. And so these reactions then make the compounds more easily excreted in the urine and the bile. So now we get into excretion. So this might occur through the kidneys, the liver, the lungs, or the skin. And so to excrete a weak base, we want to acidify the urine, and then to excrete a weak acid, we alkalinize the urine. So just kind of, chemistry, it's coming back to haunt us. Clearance, that's the rate of the drug removal in a volume of plasma over time, or it's also known as the efficiency of drug removal from the body. And so we have that equation down below. So, these are kind of where, if we're doing these equations on the NAPLEX, I think it's going to be really good to just look at, what's this called? Milligrams per liter versus milligrams per hour, just kind of making sure everything cancels out to get what we need. I also added in rate of elimination. So it's usually steady. So the kidney and liver usually don't speed up or slow down. And that's a note that was made in the RX prep book as well. I think I wanted to add, so let's see here. So renal is the primary route, and this can be increased by adjusting the acidity of urine. But yeah. A little bit more pharmacokinetics. So first order and zero order. So first order, so this is when there's a constant percentage of the drug being removed per unit time. And zero order is when there's a constant amount of drug being removed per unit time. So in zero order, for example, even though we have 20 milligrams that's being cleared, if there's 5 milligrams, the first hour, it's still 5 milligrams the second hour, even though there's 15 left, and it's getting smaller. Whereas first order is no matter how much there's in the system, there's 20% being eliminated every single hour, for example. And then Michaelis-Menten kinetics, so this is also known as saturable, mixed order, or nonlinear kinetics. And so this is when there's a disproportionate increase in drug concentration at steady state after an increase in dose. So like lower concentrations might exhibit first order kinetics, and higher might exhibit zero order kinetics. And so in linear kinetics, doubling the drug approximately doubles the serum concentration, whereas in nonlinear, we would see that doubling the drug can actually more than double serum concentration. So we have to make small incremental and cautious adjustments to avoid toxicity. Some more of these equations that are coming back to haunt us, but they're not too bad. There's actually, so when I was going through the RX prep book, there's actually a lot less equations that I saw than what we've seen in classes. So it shouldn't be too daunting when we're studying for the NAPLEX, but here's a couple more. So the elimination rate constant, or KE, so that's the fraction of drug that is eliminated or cleared per unit time. And so we see this calculated with the clearance and the volume of distribution. And so right here, so if a KE was 0.1 hours to the -1, so that means 10% of the drug remaining is cleared per hour. I think that's still going to take me a couple times to even review myself, but at least it's on here so we can study it a little more, just kind of put it to memory. Half-life, so that's the time it takes for 50% of the drug concentration or amount to be eliminated. So that's where we see that elimination rate constant come back into play. And remembering that it takes about 5 half-lives to reach steady state. And then a loading dose may sometimes be required to more rapidly achieve therapeutic concentration. So to eliminate basically at least 95% of the drug, it takes about those 5 half-lives. And then I also wanted to note that when a fixed dose is administered at regular intervals, drug accumulates until it reaches steady state, where the drug intake equals the rate of drug eliminated. And that's kind of a little synopsis of pharmacokinetics. So now we're moving on into drug-drug interactions. And if you get the ARCS prep book, you'll see that there's a lot of examples for these. So I didn't include all of them by any means. I just kind of did the more main ones and just kind of key points I think that are good to remember. All right, so these are pharmacodynamic drug-drug interactions. So that's when 2 or more drugs are given together and either have a beneficial or harmful effect. And so we see this with antagonism or synergism, for example. So antagonism, we might see an antagonist and an agonist. And so in this case, the antagonist usually is what blocks the agonist. And so an example of that would be an opioid and naloxone. And then for synergism, so that's 2 drugs that are acting together to produce a greater effect than if they were taken individually. So 2 agonists, there would be an additive effect, same receptor, or additive effects with greater than 1 mechanism or receptor being activated. So example of this, benzo plus opioid, but together those would have profound sedation, respiratory depression, coma, and even death. So that would actually be harmful in synergy. But a good example other than that would be like hydrocodone plus acetaminophen, and together they have more analgesia, which is helpful. So pharmacokinetic drug-drug interactions. So that's when a drug alters the absorption, distribution, metabolism, or excretion of another drug. And this can also be beneficial or harmful. And one of those interactions we have to think about is chelation. So that's when a drug binds to charged ions. So you think about that, certain drugs you can't have iron or calcium or whatever. So one drug might increase or decrease the absorption of another drug. They might inhibit or induce metabolism of another drug, and then increase or decrease excretion of another drug. Going to this more in depth, so drug removal and breakdown. So this is mainly in the kidney and liver. So in the kidney, so urine is mostly water, and drugs and drug metabolites need to be water soluble to have adequate excretion. And then liver, when a drug is in the process of being converted, that's to be removed. It has to go through those phase 1 and phase 2 reactions like we previously talked about. And this is where we see those CYP enzymes come to play, especially in these DDIs. So especially when a patient has, some of these CYP enzymes are polymorphic. They might express an ultra-rapid or poor metabolizer form of that CYP enzyme. So the enzyme inhibitors and poor metabolizers generally increase the drug metabolism, and then enzyme inducers and ultra-rapid metabolizers decrease the drug metabolism. But we do have that exception of prodrugs, which have the opposite effect relative to the either inhibitor or inducer. And that's because, as they're being first metabolized, they're going from inactive to active. And so it's important to know if the victim is a prodrug or not. So here's what we see with those CYP enzymes, the main inhibitors and the main inducers. And so they try to come up with those, what are these called? Mnemonics. So G-Pac-Man for inhibitors and PS-Porks for inducers. Not my favorite, but I think that's what everyone's teaching, and that's what's in the RX prep book. So here it is. So grapefruit, protease inhibitors, the azole antifungals, etc. St. John's wort we see a lot of, definitely the rifampin, smoking, etc. And here's a chart. So the CYP activity, and then the genetic type or the polymorphism, and then ethnicity differences. I don't think that's something that we would be tested on, but it's just kind of good to know and have in the back of your head. Here are a couple of the common drug interactions. So definitely amiodarone, warfarin, digoxin, and then together, so CYP2C9 is that main enzyme for these being metabolized. And when this is inhibited, there might be higher warfarin levels, indicating, there could be a possibility of a bleed. So we'd have to monitor the INR and adjust as needed, because, pharmacy and it's not black and white. So sometimes people do need to still be on both of these medications, but thankfully warfarin, you're being under a watchful eye anyway. Amiodarone digoxin, so this is where PGP comes into play, and so that's inhibited and would cause lower concentrations of digoxin and possibly higher toxicity. So we'd have to monitor the serum concentrations, electrolytes, and renal function. Definitely we see the CYP3A4 interactions with statins, so we have to be careful of that. Some of the statins aren't CYP3A4, so you also have to look out for that. I think there's 4 main ones. I don't think rosuvastatin is CYP3A4, for example. And then rifampin, so that's one of those big inducers. So most drugs basically will interact with that. And so concentration of the victim drugs will usually be decreased, unless it's a prodrug. You always have to remember that. And then some more. So a lot of these anti-seizure medications with the CYP drugs, just watch out for that. Smoking, so antidepressants, hypnotics, caffeine, especially, and theophylline. I think those are the ones that have the really similar structures, and then insulin as well. Got to be careful with that. And then the motrigine and valproate, really good to review this. So that's basically it for the DDIs that I have. Again, there's a lot more that they list in the book, but it was just too much to put on here. So I just listed the main ones. Definitely good to go and review. Now we get into the last section, pharmacogenomics. So this is the science of examining inherited variations in genes which determine a patient's response to a drug. And so it's also known as personalized medicine, and that increases efficiency in choosing effective regimens while trying to decrease side effects or adverse reactions. And so it's estimated that about 20 to 40% of drug metabolism variations are due to these genetic factors. So it's actually covered more and more by insurances. And so it's also becoming simpler to perform the genetic testing. So I think we're going to probably start seeing it a little more, but we'll see. Like, for example, psych medications, these are historically hit or miss. So if we have that genetic information, that'll help us target our therapy a little bit better or faster, be a little bit more efficient. Some more important pharmacogenomics terms, so genes versus alleles. So genes, that's a specific set of nucleotides that code a single protein. It's also known as the blueprint of life. And then alleles, this is a specific form of the gene, and so that can either be the wild type or the variant. Wild type is usually the most common occurring. And then if we would see 2 of the identical alleles together, that's when we see homozygous. And then, so an example of that would be like CYP2C19 star 1 star 1. And then if we saw heterozygous, so that's two different alleles, and that would be, for example, CYP2C19 star 1 star 3. And that can determine kind of the dominant versus the recessive expression. And then a SNP, let's see here. SNP, that's a single nucleotide polymorphism, and that's actually a change in the single nucleotide of the gene sequence. So for example, A to T or G to C, and that's the most common genetic polymorphism in DNA. And it can either be harmless or it can cause a disease. And that's usually responsible for the majority of individual variability in response to a drug. And then I guess I'll just add to, genotype versus phenotype. So genotype being a set of unique genes to determine a specific trait, and then the phenotype being the observable trait or the outward expression of a genotype. So actionable pharmacogenomics. So the testing that is required or strongly recommended is definitely in abacavir, azathioprine, carbamazepine, cetuximab, and panitumumab. Wow, that's a mouthful. And then trastuzumab, adotrastuzumab, lapatinib, and pertuzumab. And then testing considered but not required is in the other ones listed here. So especially in that codeine, because that's one of those prodrugs, can cause a toxicity or no pain control. And we're going to go into that a little bit more now. So these are the drugs that we see the HLA testing in. So that's human leukocyte antigen testing. And so abacavir, this is where we see the HLA-B 5701. I think that was, drilled into our heads in pharmacogenomics class. And so it can cause a fatal or serious hypersensitivity reactions, and that's why it's really important to test for that one. And we have to test all patients who are taking that. And if someone is positive, we cannot use it. Do not use. Allopurinol, kind of the same. So HLA-B 5801, so almost the same thing. But this can cause the Stevens-Johnson syndrome, and we would have to discontinue at the first sign of that reaction. And definitely do not use that one either if that comes out positive. And then we see the seizure medications. This is HLA-B star 1502. This one also has a Stevens-Johnson possibility, or the toxic epidermal necrolysis. And so that's actually more common in the Asian populations. And so I guess, testing Asian patients before starting these is recommended, which I actually didn't know. So that was interesting to me. So if positive, again, do not use, unless the benefit outweighs the risk, but I don't know how often we would see that. So these are the CYP polymorphisms that we're going to see now. So clopidogrel, CYP2C19, and that one is the prodrug. So we have to be cautious in the poor metabolizers. So that would be star 2 or star 3, because they could have the increased cardiovascular effects. Let's see here. Let's see. And that means not necessarily bleeding, because if we were increasing to the active form, then there would be more antiplatelet effect. So if we're not doing that, there's more of a chance of those cardiac events happening. And so we would want to consider an alternative if they're star 2 or star 3. For codeine, so that's also a prodrug, and we need to be careful in the ultra rapid metabolizers because of the increased risk of an overdose or that respiratory depression. And that's, I guess, infant deaths can also occur in pregnant mothers who nurse, especially in those ultra rapid metabolizers. So if they are, don't use because of the toxicity risk. And then, if they're a poor metabolizer, don't use because there's a lack of efficacy. Then for warfarin, so, we can test for these, but it's not going to determine whether or not you should or should not be on it, but it's good to know because there could be an increased bleeding risk. And that's what we normally see the star 2 and star 3. and those are the more decreased function alleles. We would also see a V-Core-C1 G to A variant. And so we would want to start with a lower dose if these are present. And then these, so trastuzumab, so this is the HER2 gene. And so I don't know if you guys remember, but Dr. Kim gave the good example, put your trust in her, or it's like trust or whatever. And so if that is negative, then you do not want to use. So that's something we're going to have to remember. So a lot of these are, oh, if they're positive, don't use it. But for HER2 and trastuzumab, don't use if it's negative, because then it won't have that effect. Let's see here. And then for cetuximab, this is a KRAS mutation, and so we only want to use it in the wild type. So if it's positive, we're not going to use, because otherwise it's not going to be effective in the colorectal cancer. And then azathioprine, that's TPMT. We have increased risk of severe or life-threatening myelosuppression if it's low or absent, that TPMT activity. So we might want to start with a low dose or use an alternative agent if there is low or absent activity. And then capecitabine and fluorouracil, those have a DVD deficiency, which stands for dihydropyrimidine dehydrogenase. And this is increased risk of severe toxicity, kind of like the diarrhea, neutropenia, neurotoxicity, if that deficiency is present. So if it is, best not to use those. And this was just kind of, I was posting this here as a reminder for CPIC guidelines. And so you would go to cpic.pgx.org. And then you would click on guidelines. And this is what comes up, and it shows what has been recommended. And then the prioritization, so let's see if I have it here. So yeah, the level A or B, so this is when they definitely recommend a prescribing action. And then level C, we don't really need to make a change, but alternatives, might be applicable. And that is all I have. Hopefully this was helpful, as just a little bit of a review, Kickstarter. What questions do you have? And I do have my chat pulled up if you want to type it in there. Jacob says, I forgot everything. Thanks for the review. No problem. I jumbled my words. I'm sorry. I didn't get to practice because rotations have been a bit hectic. Definitely recommend getting the RX Prep book, STAT. It's been really helpful. And sounds like we don't have any questions, so I hope this was helpful to the rest of you guys. And for those listening in the future, good luck. Again, please send me any emails if you have questions, or, feel free to reach out to the professors or look up any, clarifications that you're needing. Thank you.